I am really interested, Richard, that you would think there's a role for inhaled steroids. Is this only in the group of children who have got allergic rhinitis?
Well, it should be in any child that John sees or any pharmacist sees that comes back having multiple antibiotic prescriptions. I mean, really, we were talking about this before. I mean, what type of childhood bacterial infections really need to be prescribed antibiotics? The list is actually very, very small of things that are outside the serious stuff.
Sure.
Of meningitis, lobar pneumonia, sepsis. The list is actually very, very small. So I think as a pharmacist, if you see a parent with young children seeking antibiotics over and over again, I mean, I think that's like a flag for someone who needs to maybe a discussion of what's going on, because
although I think it'd be a brave pharmacist who'd go there, wouldn't it?
That's right. I mean, we do see those occasions, certainly, Richard, and but what we recommend generally is they go back to the doctor. I mean, the doctors initiated those prescriptions in the first place. They haven't come from us. But you're right, it is a worry. And I think there's much greater awareness in recent years of just how big a worry it is. And it's probably more of a concern when children are getting multiple prescriptions of antibiotics than adults, because their young microbiome is so, I guess, open to change and therefore predisposition to whatever. Certainly you would think allergic problems, asthma, other allergies, maybe even, as we've thought now, things like diabetes and cardiovascular disease.
But just being really clear about it, Richard, because this is fascinating, and I think a lot of other GPs like me would be really interested in it. With the group of children who were obviously atopic, had eczema, had asthma, were, maybe already using a preventer for their asthma, that group, I think, would be very comfortable. I personally would be very comfortable that inhaled nasal corticosteroids were very appropriate in that child and should be highly encouraged.
Well, actually, you keep going, because I was going to say that rings flags, that child, to me. When I hear that story, when someone who is atopic, has dermatitis, is using, when I call inhaled, I think of ones you breathe into your lungs, inhaled and intranasal corticosteroids, all of a sudden now you've got a child that is using a lot of suppressive medication to control their allergy. They've got multiple organs that they're treating, and their corticosteroid exposures cumulatively is going to be quite high. They're the sort of group that I would be very cautious when I add another corticosteroid in, and I would say, look, maybe we need to talk about other ways of managing your allergy, such as immunotherapy or sort of other treatments. What was the other group that you were going to suggest?
Well, I was thinking that group we're quite comfortable with, but the child who, is getting their normal run of colds, we should have perhaps more of a conversation about whether they could have allergic rhinitis. But that group, I would be quite cautious about suggesting that intranasal corticosteroids were...
So I have no problems recommending intranasal corticosteroids for episodic events. When you can give it to them, they can buy it over the counter, they can start it at home, they can use it in the first few days, 5-10 days of when they start to get symptoms, and it really doesn't matter. Are those nasal symptoms, the congestion, the mucus, is it virally driven? Have they just had a lot of allergen exposure and have a bit of allergic predisposition? I would much rather them have a set of tools that they can use to help control those symptoms when they come on, and things that they can initiate themselves. And you can combine it with some decongestants, you can combine it with some paracetamol.
So even in the group who you aren't thinking of as particularly atopic, you feel comfortable with them using... Totally. But I'm a little bit confused when you said, look, virtually we don't have to worry about intranasal steroids because their first pass metabolism means that, you don't get any systemic thing, but on the other hand, hang on a tick, they're having both, we better be frightened about it.
So it's not that we should be very careful. My statement said we shouldn't be worried. We're always worried about exposure, but it's a relative thing. And so, to me, a child who's using a corticosteroid cream, which is directly absorbed most of it, especially if they do things like wrap their dermatitis patches in Glad wrap. That's straight into the systemic symptom. Inhaled corticosteroids straight into the systemic system for most of it. And intranasal, which only a small percentage, maybe about 20 or 30%, gets absorbed locally, and the rest is runoff. And so once you've got the cumulative exposure of all of them, yeah, I think it's time to start saying, okay, we're suppressing our child's allergic symptoms in multiple parts of the body, but that's the child that I think needs a discussion to talk about, should they go on and see someone who might be able to offer treatments such as immunotherapy, disease-modifying interventions. So that's the group that I refer to when you talk about the cumulative.
Yeah,
exposure.
I mean, immunotherapy, you have to be, that's a big commitment, isn't it?
Yeah, but I think also if you have to sit down with children who are going through an allergic process and start to have multiple organs involved, that's the sort of things that we should be raising with them early on, rather than having years and years of corticosteroid-based treatments. If they are really that severe and needing multiple areas treated, that's the time to consider it. I personally think intranasal corticosteroids should be much more widely used for the milder conditions, and that's why they've been shifted to the over-the-counter zone, because they really should be used for a whole range of inflammatory rhinitis conditions.
So do you think it's a reasonable take-home message? I like the sense of that we would expect a topical steroid on the skin to work within a few days, and we would usually use it until the problem had resolved and stopped it. For the milder symptoms in...
Yeah, absolutely. I don't think that's not novel. I think it's really been established.
It's novel to me. Back to you, John.
Well, yes, I never thought of it that way, but it's
I haven't
interesting.
either.
I do accept that the intranasal corticosteroids work a lot more quickly than most people give them credit for.
Yeah.
And I'm not too sure why that perception has arisen, but certainly, going back a couple of years when they first came onto the market, there was always the indication that or the suggestion we should say to our patients, look, this will take a fair while for you to get any benefit out of it.